Hey y'all, this is Dr. Acker. I wanted to provide you guys feedback on that Module 4 Discussion 2 that you finished last week. I finally finished grading it. Be sure to check the grade book for your grades and then also check next to your grade. There should be a little button that says Assessment. Click on that as you'll find the rubric there, and over to the side you'll see comments that I gave you on your personal discussions, areas that you can improve, things that I really liked. Um, and so just be sure to check that out. So, this is one of the things I do to try to stay connected to you guys since we are online. Having discussion online is fabulous. However, this is the one thing I miss about live class because I would love to engage you in a conversation and see what you have to say. So, it is Wednesday night about 10 o'clock, and I obviously am running behind. As you know, I'm back having surgery tomorrow, so I'm unavailable for the rest of the week and maybe next week. I'm not quite sure yet what that's going to look like, but if you have an emergency, Dr. Deborah Bailey will be watching over our class. Don't fret, everything is up for next week, and you guys are more than welcome to get going on that on Saturday, and things will run smoothly. But I just wanted to make sure I got you some feedback before the next discussion so that you knew what I was looking for. So let's get started. I will warn you that since it's so late, I did not make a script for this, and this is going to be a very, very basic PowerPoint. This is just my way that I can actually talk to you guys as a group. So forgive the errors and the boring PowerPoint because usually I do a lot more with them. So here we go. First of all, I want to say the majority of you guys are first time graduate students. This is your first course, so awesome job. You guys did a great, great job on this case study. Um, I wanted to go over with you after grading and everything, some course expectations for discussion. Um, Everything in graduate school you should hopefully find within your syllabus. So make sure you guys are reading those inside and out. If you have a question, try to refer there first. And if there is a rubric available, you want to look at it, make sure you understand it, and you want to meet exactly what that rubric says. So for discussion, let's go over the rubric really quick. Um, the only areas that people lost points in this week were posting late. I am a stickler for being on time. It makes it really hard to discuss if only half your group shows up for half the week. And by the time they show up, the discussion is already formulated, ideas have been made, and you guys are trying to post final answers. So it's really important to post on time. The way that the discussion is set up is that you guys will post your initial post before you can see everybody else's. So what I don't want to see is you posting a little simple comment like, "Hey group, how you doing?" or "Do we have a plan for this week?" Because then that will open up discussion for you, and you'll be able to see everybody else's post. Um, the reason I do that is because these questions are usually fact-based questions to start with. And so everybody can pull the same facts from the same resources. I want to see if you can come up with something a little unique. I want to see how you think and what you're thinking about. I don't want you to grab that idea from your peer, your classmate as you guys are trying to do that. Then once everybody has their post up, then it's time to actually discuss. And this is where it differs from undergrad to graduate, is that in undergrad, we strongly want our discussions to occur. We want you to go back and forth and kind of have some discussion, but without a lot of real life experience, you can't really discuss too much other than facts. Grad school's awesome because you guys are already out there working. You've seen these conditions, you know how they present. You may not be writing scripts and orders on your own quite yet, but you certainly know how to take care of your patients as you're with them 12 hours a day. Um, so it's really, really important that in discussion, don't be afraid to express your ideas. Challenge your peer. If you think that they are just crazy for what they're saying, tell them in a nice way and provide some evidence to show them why you think it's another way. If initially you say that you disagree with a diagnosis, for example, then don't just agree later in that week without any explanation of how you were convinced or why you went ahead and went with the group. And it could be something, as simple as I'm going with the majority, but I still want you to be able to rationalize it. If you can't rationalize what you're doing, then don't do it. Also, I would really like to see when you say, oh, I agree with all the differential diagnosis. Tell me why. What about that case presentation made you say yes to that differential diagnosis? Sometimes that's really easy to see in a chart, you know. You put it in a chart form, you can say, yes, it has this, no, it doesn't have that. And now you can kind of get your idea for your diagnosis. So this course is really about pathophysiology. It's less about diagnosing patients because that'll be taught in your adult class. If you continue on to the F&P program, I also teach that. So I like to think that this is like the beginning class to adult. And then when I get you guys an adult, I expect you to remember this. And then that's where we hit the treatment and how we diagnose and what we order really, really hard. So I want to expose you to it here, but don't feel like that's your ultimate goal in discussion. Also, discussions may vary. We may have case studies, we may have projects, we may just have chats. It just kind of depends on what's going on that week. The other thing I want to commend you guys on is that you are definitely thinking outside the box. Um, and I like that. Just know that for the purpose of school and the purpose of sitting boards as a family nurse practitioner, that you're not going to have to think outside the box too much just because they're trying to test for safe beginning practitioners. So usually you're not going to see a zebra. So a zebra are those things that you're really reaching for, that it could be this, but probably not, but I'm going to go ahead and chase that trail anyway. So remember that. You want to try to stay away from zebras. It's usually your most basic concept that you are thinking. So that's kind of course expectations for discussion. But overall, great, great effort. I let you guys get off topic quite a bit this week, and just I wanted to see where you went with it. And that's just kind of fun of discussion to be able to watch. So good job. I will tell you that um, this is an individual grade. Even though you work as a group, you do not get a group grade. Okay. I look at everyone's individual participation and what they put forth. So don't feel as though your group is helping or hindering your grade. The other thing I want to tell you is that don't be afraid to give an answer. You're not scored on if you're right or wrong in discussion. As you know, when you become a provider, a patient may present and it can be treated multiple ways. Hence, that's why we have differential diagnosis. I may go down, diagnosis A, and you may go down diagnosis B. We'll test our patients and may come up with the same diagnosis at the very end. So there's more than one way to treat a patient. There's 9 times out of 10, there's not a straightforward right or wrong answer. So, well, let's get started with this discussion that we had. So, we all know, I don't think I need to read the case study to you again because you spent such long time with it. So let's talk about when we look at a case study. I saw that I wanted to kind of walk you through how I look at a patient that presents to my clinic. I want to look at them with what do we know? We just want to know, or you want to list exactly what you know to be fact. And in this case, we know that Tina is a 58-year-old female. We know that she has a chief complaint of um, malaise. I am going to need that. Hang on one second. Sorry. I'm not going to read the whole thing to you, but she does have, a chief complaint of fatigue, weakness, palpitations, tachypnea, dyspnea on exertion for the past 2 months. We know that that's getting worse. We know that she states that she has no past medical history of importance. We also know that her nutritional status, she states, is healthy, although when we look at her hydration status, that she has picus. She definitely eats a lot of ice. She drinks a little fluid. Um, we know from the physical exam, this is fact, that she has a temperature of 99.4. Fact is that is not a fever. Okay. She has a heart rate that's irregular. We don't know exactly because we didn't see an EKG, so we don't know what irregular is at 116, so she's tachy. She has a blood pressure of 90/46, which could be normotensive for her. We don't know, but these are facts. Respiration is 22. She's pale, and the rest of her exam was normal, with the exception that she has brown guaiac positive stool. Okay, so those are facts that we know. So that's all we can really work with since we can't talk to her and get answers. So let's talk about our assumptions, questions, and what we really don't know. So I put this little PowerPoint together just to kind of show you guys the difference. I don't know if you were following each other's discussions, but there's group one and there's the Germinators. I think that is a cool name. Good job on you guys naming your group. And group one, I didn't see you guys make an effort to name your group, so feel free this week if you guys want to do that. We will have names for you. But the assumption that group one had, and I took some of this from your final answer and some of it I just kind of gleamed from your discussion this week. But group one assumed that she was postmenopausal because she was 58 years old. I can tell you that 58 years old does not make you absolutely in menopause. Menopause is the absence of a period for over a year, for 12 months or more. So I know many 58-year-old women that still spot, that still actually have periods and are still fertile, believe it or not. So we cannot assume that she is postmenopausal. It looks like the germinators also had that same assumption. Both groups also had the assumption that there is a positive guaiac stool, therefore she had a GI bleed and or some sort of GI malignancy possibly. And you went down that rabbit trail, that zebra. Uh, Actually, that's actually probably not a zebra. That's kind of a good thought. But I'm going to walk you through why we're going to take that off the table there. Um, and we'll do that in a couple slides to go. Group one. I noticed that somebody in the group questioned the patient's reliability. Um, is she really have a normal, healthy diet? Or is that just what she told us? Since we don't really have a 24-hour diet recall, we haven't done anything like that with her. We don't know if she's reliable. But like I said before in one of the discussions, you got to believe about half of what they tell you. And if it's about smoking, you double what they tell you. So if they're smoking half a pack, they're really probably smoking a pack. If they say they're drinking 8 glasses of water a day, they're probably drinking 4. So that's just something to keep in mind. But we don't know. We have to question reliability. Um, the germinators, they also brought up, which I thought was a great thought, and I know this stems from those St. Mary cardiac nurses that we have in the class, that maybe it's a cardiac etiology. I mean, if you look at it, other than that guaiac stool, um, it could be like an AFib. Um, so that's actually a great idea. I don't know that it would make my top three, even if I weren't teaching this class and we were talking about anemias this week. Um, and I think the reason is for that is that with that guaiac stool, um, she doesn't have any other um, complaints that you would have with an AFib, other than that irregular heartbeat. Um, Let me take that back because I know y'all are just cringing when I said that. Let me tell you, I was a cardiac ICU nurse for 14 years before I became a midwife and before I started teaching. So yes, she does have AFib um, issues, so such as um, shortness of breath, tachycardia, dyspnea on exertion. So those are all those, but I'm going to tell you later how that's not going to fit into this. Um, let's go to some differential. Whoops. Let's talk about these differential diagnosis that each of the groups came up with. Let's start with group one. Group one's number one, I think all the way across the board, was iron deficiency anemia. And yes, that is what we are going to say that her most likely diagnosis is, as we don't really know, but that's what we think it's going to be because she sort of fits that picture, and we'll talk about that. They also went with thrombocytopenia, which I thought was interesting. Um, if they were thinking that number one, she has anemia, then we're going to start thinking of, well, if it's not anemia, what else can it be? What else is going to make her tachypnic? What else is going to make her have irregular heartbeats? Thrombocytopenia doesn't make that happen, but I can see where you guys are reaching. If you think she has some sort of GI bleed or GI malignancy, the bleed could be caused by a thrombocytopenia, which is simply a reduction of platelets, honestly. And so, what you're going to see in those patients is a lot of bruising, a lot of bleeding, whether it's gums. And if you're thinking, that it is a GI bleed, I want to also remind you that her stool was brown. If you have something that is bleeding a lot, bleeding enough that it's going to cause anemia, acute anemia, then you're going to expect to see that melena, that dark black stool that we're so used to with GI bleeds. So we're going to keep moving on theirs. Their last one was aplastic anemia. Okay, and so aplastic anemia is sort of an interesting idea. When we look at aplastic anemia, it's usually some intrinsic bone marrow dysfunction or failure that is going on with those patients. When you look into it, it's really not that common in the United States. 50% of it is idiopathic. When we talk about idiopathic, let me back up. The thrombocytopenia, it simply could be low platelets. There's also that idiopathic thrombocytopenic purpura that you're going to see in pregnant women. They just become low platelets, and you worry about bleeding and postpartum hemorrhage with that. I just want to throw that in there for later. So back to aplastic anemia. Like I said, it's not really common in the U.S., and it's usually caused by some sort of exposure to chemicals, toxins. You usually it's a really quick onset with a fever, weight loss, you get sore throats, but you do have some dyspnea and palpitations. You do have some epistasis. You might even have some rectal bleeding. Um, but again, she didn't report any history. We can only go with what we know. She reported no history to toxins, medications, or chemical exposures. So, that's pretty low on the list, I'd have to say. But I like your guys' thinking on it. So let's move over to the germinators. Oops. They also came up with iron deficiency anemia as the first one. The second one, and I'm going to grab what they wrote, their GI bleed. GI bleed is the most common cause of iron deficiency anemia in adults and postmenopausal women, is what they said. So again, we can't assume that she's postmenopausal. Um, their third differential diagnosis was hemolytic anemia. Now, I did want to talk to you a little bit about hemolytic anemia. So you look at this, and the real cause, the pathophys behind hemolytic anemia, is that it causes anemias because the accelerated RBC destruction occurs because the intrinsic genetic RBC defect, such as things you're going to see in sickle cell or thalassemia, you're going to see it in your metabolic enzyme deficiencies like G6PD. Um, and some extrinsic causes of it, might be such as an autoimmune disorder, some sort of drug-related reaction, maybe even a transfusion reaction. Um, so when we look at this, if you think up front, this is how we rationalize. If you think up front that what condition is going to cause some sort of rectal bleeding, is going to cause uh, or let's start again. If you look at symptoms, she has what condition has symptoms of some sort of rectal bleeding? She's tired, she's pale. You have her eating ice. You have her doing these things, and you guys are right with iron deficiency anemia because that was what I put for the first answer. So now let's talk about why it's not the other ones that you put. So let's look at hemolytic anemia first. So when we're looking at iron deficiency anemia, we know that that's a microcytic hypochromic anemia. But then yet you're going with hemolytic anemia that doesn't quite fit that same bill. Um, and it may even be a hyperchromic. So give me one sec. I want to see if I can find this in your guys' postings. Nope, I don't see what I was looking for. I didn't know somebody talked about with the hemolytic anemia that it can be caused by an alcoholic cirrhosis. Um, and as I just did, we haven't talked about if she was a drinker when we talk about her nutritional status. But really looking at hemolytic anemia, um, you're not going to see the same type of cells. You're going to have a megaloblastic anemia with that. And so if you're looking at differential diagnosis, I want you to think about what other hypochromic, anemias might you see? You might see a lead poisoning, you might see a thalassemia, um, but try to stay within the same classification of anemia. Moving on, my second diagnosis would have been anemia of chronic disease. When we look at that, we look at the description for it would be something along the lines of it can be associated with some sort of chronic disease, infection, malignancies. So you guys hit up on all those, but you're really focused on the GI tract with that. The real ding ding for me on that is that it lasts greater than 1 to 2 months. Um, and when it lasts that long, it's usually probably something that's inflamed. So the etiology of the chronic, kind of like the pathophys etiology of the anemia of chronic disease, we really don't know a lot about it, but we do know that there's a decreased RBC lifespan, erythropoietin reduction, and a lot of problems with that iron transfer. Um, Sometimes it can occur because of renal disease, liver disease, rheumatoid arthritis, and as you guys know, some sort of GI cancers can make this happen. Some things to look at um, with this. Well, let me tell you my next one. This always throws people. Thyroid. When in doubt, check your thyroid. Thyroid mimics almost every disease you can think of. If they have a symptom, it can be caused by a thyroid. So if you do the workup for anemia and you can't find it and she's not anemic and you can't figure anything else, always check a thyroid. You can never go wrong. This little pearl of wisdom. And I'm not going to tell you a lot about the thyroid disorders because we are going to get to those later in this semester. Lab expectations, that was your next question. What are you guys going to see on this smear? And I'm assuming that we're talking about a iron deficiency anemia. So you're going to see a microcytic hypochromic anemia. When we talk about labs, this is really important that you guys get this concept, especially if you go into my adult class and as you start seeing patients. We are going to talk at length about how you read a CBC, what it means, and what it doesn't mean. I'm also very conscious about healthcare dollars, so I'm going to tell you, what you could order and what you can get by with ordering. I think as we see healthcare move in to fee for service and fee for outcome, that people are going to stop ordering the moon. And that's kind of the path you all went down. You guys walked through, oh, she has these symptoms, and we're going to do a whole GI workup. In fact, while I'm on that subject, I took some notes. I think people wanted, let's see, what did y'all want to do to them? Colonoscopies, GI workups. Um, I am proud that nobody said bone marrow aspirate, but that's always a possibility if you walk down that path. Um, so when we talk about working this patient up, there's really only a couple things that you actually have to know to be able to diagnose an anemia. If you memorize a chart, you guys make a chart of the most common anemias that we have. You know, if you do chronic disease, if you do one that is iron deficiency, maybe a thalassemia, sickle cell, I mean, that's African American. Thalassemia is more Mediterranean. Just do a little quick chart of your basic findings for hemoglobin, MCV, so you want to know the volume, and ferritin. That is going to tell you the world about what's going on with your patient. So if I had this patient in my clinic, I see primarily illegal immigrants that speak Spanish with no money, and they are paying cash for everything. So yeah, it'd be great to get a CBC and a ferritin. That CBC is going to tell me quite a bit. And we start when we look at a CBC, we start looking at the hematocrit. Okay. Um, We also look at the hemoglobin. Now, here's a little trick for you. Your hemoglobin or your hematocrit should be 3 times your hemoglobin. So if your hemoglobin's 10, your hematocrit should be right around 30. So it's kind of nice to know those numbers if they're right on top. Um, when you look at your MCV, your mean volume, it represents the size of that red blood cell. And you get it from a calculation that has to do with like your hemoglobin, hematocrit, um, and it helps when we differentiate between different anemias. So if we are going to diagnose this patient, as simple as can be, we would look at it and we would order this and we would look and say, yes, she has anemia because her hemoglobin is low. Other factors that may make that hemoglobin low, other than bleeding, may be dilution, it may be elevation. Yeah, your hemoglobin changes with elevation. Um, and then a ferritin. A ferritin is a great test. It basically shows the iron storage in the serum. The only problem with that is that it can be elevated with an infection, or it can be decreased, and it should be decreased in like an iron deficiency. So the other things you want to look at are the size of your cells. You also want to look at that red blood cell distribution width, and that's something we are going to get into. I think it's another couple weeks we start talking about that to actually really go through that. A lot of people want to get busy and order that total iron binding capacity test. That is really for the amount of iron in serum plus the amount of transferrin that's available. If you guys remember, that transferrin is what transports the protein that regulates iron absorption. So they kind of go hand in hand, but it doesn't matter about your absorption if you don't have the ability to store iron. So you always want to start with less. So we're going to start with ferritin because we want to know, can she store iron? Is that really the cause? We look for that first because that's typically the number one cause is iron deficiency. Um, when we look at iron deficiency, excuse me, um, we want to, you ask yourself, well, why? And it has mostly to do with the iron stores. They're not able to store enough iron. Um, Somebody hit on this in one of the discussions that with that pica, that it can cause impaired absorption, so you can't even absorb it. Um, Other conditions, I don't know, like maybe a neoplasm. Somebody did talk about a gastric ulcer, diverticulosis, even ulcerative colitis can cause where you get an iron deficiency anemia. So if I were seeing my patient in clinic with no money, being health conscious, I would simply get a hemoglobin, an MCV, and a ferritin. What I would expect to see is I'd expect to see my hemoglobin low, my MCV is low because you don't have a lot of volume, and I'd also want to see my ferritin low because that means I can't store iron. It doesn't matter if you give this patient oodles and oodles and oodles and oodles of iron. If you're not seeing this immediately come up, you might want to look somewhere else because it's just a matter of absorbing it and storing it. So oftentimes, if we see a low hemoglobin, because we'll check that on our patients with a quick finger stick in the clinic, if they have a hemoglobin, we automatically put them on iron. If they take that iron, they're able to absorb it, they're able to store it, their hemoglobin is going to come up in a month or so when we see them again and recheck it. Then there's no reason to do anything else. You've done a simple finger stick POS in your clinic. Um, if they come back in a month and they swear that they've been taking their iron, which they usually haven't been, but if they say they have, then we'll proceed and draw labs and try to get a CBC and a ferritin if they can afford it. So, sometimes you treat before you know. Um, Oops, I have a new mouse. It's just kind of doing its own thing. So, the next question I think was about, let's see, lab tests that we would order. We just talked about that. Then the fourth question, what was the pathophysiologic mechanism of the dyspnea, weakness, and fatigue? Both groups got that great. I don't think we need to go over that tonight. Um, I want to kind of go back to that first slide of assumptions where I really want to talk about this guaiac stool. I posed this to one of the groups. Can anybody come up with a reason you may have a positive guaiac stool other than GI bleed? And I got a couple good answers. I got colon polyps. I got a GI malignancy. Um, and I was really hoping, because you guys are so out of the box thinkers, that you guys are going to think about this. This patient comes in, No real complaints, no abdominal complaints. So, you'd think if her gut was bleeding, she might have some ulcers, she may have some peptic, uh, some GERD, something like that. She's not dropping a lot of blood, or else she would have melena in her stool and it wouldn't be brown. Remember, she had brown stool. So, some other things that can cause positive guaiac stools that are really simple that nobody thought of was hemorrhoids. Think about that. Your stool is brown, it's not black, so you're not actively bleeding out heavily. It may have just been a smear. We don't know who did that guaiac. We didn't see it. We just got reports it was brown and positive. So, number one thing I would say, not only history is important, I would want to do a full exam on this woman. Do you have do you have hemorrhoids? Because maybe every time you poo, you get a little streak of blood. Uh, the other thing, let's do a diet recall. She's supposedly, quote, healthy. Well, what time of year is it? Does she have a garden? Is she eating beets? True story. I went to the ER thinking I had a massive GI bleed, acutely because it was bright red and coming out. And it was ended up being positive guaiac stool. I was all freaked out last year, and it was because I ate beets. So red Kool-Aid can do the same thing. So really a good history. So let's come up back here. Sorry, here we go. Less is more. When we think about this, we have to really be protective of our healthcare dollars right now, especially in rural Colorado, rural anywhere. People can't afford healthcare, it's expensive. With Obamacare, we're soon going to be looking at fee for service and fee for outcomes. You don't have a good outcome, you don't get paid. Or you see a patient with anemia, I'm only going to pay you this much money. How are you going to take care of them? So less is more. Sometimes you need to start at the beginning and get an answer back before you try to move on to rule it out. Um, that's actually a really good way to practice. Sometimes patients get really upset that we're not doing more for them. They feel like if they come see us in a clinic, we need to be doing something for them. Um, with this patient, the things I would have stressed that I really would like to see in some future discussions is start thinking about it as though you're a provider on your unit. I know most of you guys are working in the hospital at St. Mary's, so when you guys get an admit coming in and you see this patient that's techy, that is short of breath, pallor, guaiac, start thinking, gee, what else do I need to ask them? So talk about, when there's things you want to order, things you want to do to confirm. It could have been a simple, let's have a really big history. Let's talk about, your diet. Let's talk about, have you had any incidents of being exposed to chemicals, those sort of things. But more than that, a great exam. Nobody mentioned that they wanted to examine this patient, which I thought was odd. Um, if something's bleeding, you got to look at it. If something hurts, you got to touch it, right? So a lot of people ignore the anus. They don't really want to take a peek down there, but a lot of times it's a simple hemorrhoid and you guys can just move on. Um, so the key with this was what I really wanted to see that I did not get. Have a good history, have a good exam, talk about it at least. You don't have to list out everything you're going to say, but at least say, hey, we better look at that, or maybe I want to look at this. I wish I had more information. Um, and just really being responsible with their healthcare dollars. The other thing I just wanted to tell you before I left you tonight is when you guys are looking at these differential diagnosis, remember there's more than one way to skin a cat. We both, if you have two providers in the same room, they get presented with the same patient, they may treat this patient totally different to come to the same outcome, or they may get two totally different outcomes. And this is why I like to say it's called medical practice, not medical perfect, because that's all we're doing, honestly. It is scientific, but again, it's a practice. We give you a medicine, it doesn't work. Let's give you another one and see if that works. We're practicing and hopefully we're perfecting it at some point. So, really, feel free to grow in this class. Um, just really focus on the basics of these conditions that you're seeing. I will tell you that I did post discussion for next week. Um, in discussion board, there you'll see one that says discussion for group one, and then there is a discussion for the germinators. They are two different case studies. So I would encourage you guys to look at each other's case studies, maybe even at the end, so that you can grow and learn what they're talking about. But I would ask that you don't post to a group that you're not in because that makes it way confusing. So stick posting with your group, but kind of spy on the other group if you want. Um, I will not always do these feedbacks via video, but I just wanted to touch base with you guys, let you know what's up, and tell you great, great job. So I hope this was helpful. Feel free to drop me a note in the Ask Your Instructor box if this was helpful, if it's something you want me to do again, or if you felt like it took a lot of your time that wasn't worthwhile. I accept that feedback, good or bad. I just want to be able to give you guys a class that you can learn from and grow with. So, with that being said, have a great week, have a great weekend, and I will try to touch base next week sometime. And take care.